Good morning, ladies and gentlemen. Welcome and thank you for your patience. And hello and good morning to all of you joining us online today. This is the first time I've seen you. Day 3. Thank you for joining us. I'll do the big whole fireworks greeting for all of you a little later, maybe at the end of the day when everybody is in. For now, we want to move into a very, very important, extremely insightful conversation we're going to have, brought to us by Farm Access. And this is going to be a discussion about the interoperability in practice, building connected care from pilots to scalable systems. The gentleman who is going to walk us through this entire discussion is none other than and I was told I need to make sure I add the. It's not just or Mr. So-and-so doctor. It's the Dr. Tim Theory, who is the CEO of the Kenya Healthcare Federation, where he has positioned the private sector as a central partner to the Ministry of Health, including in the rollout of social health insurance scheme. He's a former president of the Kenya Dental Association and board director at KMPDC, and he advises multiple national and regional initiatives on health governance, leadership, and regulation. Ladies and gentlemen, this is a request because we're the only ones together. I have not yet this morning been in any session. This is the first one I'm doing. So I haven't got the round of applause that has woken me and kicked me in the butt yet. So I'm asking that you give that round of applause to Dr. Tim Theory as he comes to the stage. Let's go. Over to you. Over to you, Dr.
All right, ladies and gentlemen, good morning. Good morning. We've had coffee. Good morning. Thank you. So I'll quickly begin to call my panelists up on stage so that we can have an insightful session. I must tell you that you've chosen the right room. The conversations that are about to go on here will be fantastic. I'll begin by calling up Dr. Joyce Wamishwe from the Digital Health Authority in Kenya. Let's give her a clap as she comes up. Next will be Dr. Kanyenje Gakombe. He's our chairman at Kenya Healthcare Federation and runs a big facility out in Eastlands of Nairobi called Metropolitan Hospital. The next shall be Nicole from Farm Access, Global CEO. Let's give her a clap. Awesome. And then finally from Kisumu, Dr. Joram Abiero. He is standing in to represent Dr. Gregory Ganda, who could not have been here with us due to the exigencies of work. And as I sit down, I will be waiting for Dr. Steve Wanye from IntelliSoft. So let's give them a round of applause as I sit down. All right. Can be heard? Yeah. So I think this is one of the unique sessions where we get to hear from what digital health, the systems, and how they deliver care to us. How do we weave that together through interoperability? And I'll begin by saying at Kenya Healthcare Federation, we lead the private sector in the country, and our main goal is to ensure that the relationship between the patient and where they seek care is optimized. And that is underwritten by systems, and digital health systems are some of those systems that ensure this happen. So as I come to each of my panelists today, before they get to answer their question, my request is you briefly introduce yourself, what you do, and why you do it. Other than for the reasons that happen at the end of the month. So why do you get to do what you do? Joyce, I'll begin with you. She's the technical lead at the Digital Health Authority on informatics and digital health. And I'd want to say that sounds like everything the agency does. So it's in her hands. So from your perspective, what policy or governance developments have been the most influential in strengthening this, strengthening the Kenya Digital Health Foundations in the recent years? So what have been the policy or governance developments that have enabled this. And the gentleman who has joined us right on stage is on the right seat. That is Wanye from Intellisoft and Health Informatics Africa, in Africa. He's the president of that. Karibu sana, Steve. So Joyce, over to you.
Yes, thank you, Tim, and good morning. And good morning. Yes, and thank you for having the Digital Health Agency on this panel. What we are here to discuss is a very interesting topic, especially for Africa, because many people have been asking us, so when is it that you saw you need to move to scale? What needed to be there? And to your question, there are various governance things that needed to be there. But the first thing, I like putting it out, is digital health did not start in Kenya with Digital Health Agency. It's been there. It's been there for about 3 decades or so. There's some work we've been trying to do with Steve Wanye to document and put down the digital health journey in Kenya. And we've done some pretty good job, but there are things that we need to finalize so that the story is out there for even other generations. So we came on board from a point where digital health has been happening in spaces like Metropolitan started digital health long before a lot of facilities knew even what digitalization is. And then in the public sector, we had the HIV program, and things were running, but they were not communicating. There was no this one place people could get the vision for where we need to go. So in comes now a very well-defined vision that was done, but based on lessons learned. And then realizing that to articulate this vision, to implement it well, certain things needed to be in place. So we had the normal e-health strategy, e-health policy, we had the Health Act, but one of the things the Health Act had already provided for was the need for e-legislation around health, e-health legislation. And in came now the Digital Health Act. So we came up with the Digital Health Act, and as we were working on the Act, we knew there had to be somebody really moving this agenda. And initially we started off as there shall be a data governance committee, there shall be a digital health committee, still premised within the Ministry of Health, but realized we would not be able to optimally implement the vision that we had if we were still holed up in a directorate within the ministry. Not that the ministry is bad, but you see, through the ministry, you cannot be able to even begin to think about sustainable financing for digital health. And in came the need to have a digital health agency. And that is where we find ourselves, and the agency is about 1.5 years old. But the other big thing was, back to articulating the vision, was having our digital health stakeholders come together, and we shared with them the vision and they input into the vision. But we went beyond our traditional digital health stakeholders. We began to see, okay, we are going to be talking about healthcare financing. Who needs to be around there? So health insurance providers. You would not typically think of them when you're talking digital health, but they needed to be at the table because we were going to have digitalization that would even affect healthcare financing, how it's done. The other group was the health products and technologies team. We hadn't, normally they would not quite be there in that space, but we needed them there. So you cannot do digital health transformation without a well-organized digital health stakeholder group that then brings ideas and brings feedback. And the other thing that has really been strong, but borrowing from the HIV program days, was we don't quite have civil society, but we have KHF. Is KHF a civil society kind of thing? But you behave like that sometimes, and it's good. because that's what drives change. So we also needed such structures in place. Initially, the traditional MOH leadership was like, no, we don't want civil society, we don't want KHF-like organizations. But this is what has continued to give us impetus to do the right thing. So you asked, why do I wake up? I wake up because every day I'm looking forward to getting a story of, yes, what we are doing is right and it is impacting a patient and it's making a healthcare provider happier when they are delivering their services. If I get that every day, and for the people who give me such feedback, I actually tell them, thank you, you've just added another few more days for me to want to wake up to do exactly what I do. So our clients are the patients and the healthcare providers. If they wake up and they say, today I'm happier because of the digital health transformation taking place, then we are heading in the right direction. Thank you.
Awesome. Thank you, Joyce, for that. I mean, you've distilled it to anchoring it in law as among the policy or governance developments that have helped this. And of course, with that comes resources that are needed for that. And I think I can attest that government has been deliberate in ensuring that that happens. I will jump into the global scene and bring Nicole right in at this particular point. Form Access has operated in quite a number of jurisdictions, in quite a number of countries, rather. And I'd want to think you've picked some lessons at policy level, people factors, technology factors, in the course of your time at being at Farm Access. So based on that, what are the learnings you can tell our good audience you've seen? And for even places that things have not worked, what are the lessons that we can pick and leapfrog so that we don't have to get into the classroom twice? Welcome, Nicole.
Thank you. Thank you so much, and congratulations to all of you who made it to the end of this week and are here for this exciting discussion. We are in many different African countries, and I think if there's one sort of common theme across all those countries, is that Africa is definitely digital first. The willingness to adopt is amazing, and I think there have been plenty of examples, including, of course, the famous M-Pesa right here in Kenya, where technology has leapfrogged services that we don't have available in many other parts of the world. So I think that's a real asset. It now has a high willingness to adopt AI technology, and we've been hearing a lot about that in these conferences. And I think also the thought leadership in regulation, I think, has been exemplary, including building institutes like the Digital Health Agency, making sure that patients are safe and protected, because health data is also scary and it can make you vulnerable. But what are lessons learned? Well, I think a lot of lessons learned are out there. I think one of the biggest things when it comes to regulation is we haven't thought about enforcement yet. And when it comes to data, you can regulate your data. I can regulate that nobody is allowed to steal my car, and I could probably find it on the streets of Nairobi back because I'll recognize it. But if somebody steals my healthcare data, I probably wouldn't even know where it went and how to get it back. So that's a big challenge. We talk about regulation, we don't talk about enforcement a lot. I think a second point that are a lot of lessons learned is that healthcare is about universal healthcare coverage, and that means it is about healthcare purchasing and it is about service delivery. And yet a lot of the digital solutions focus either on claims or they focus on getting information from the healthcare facilities. But the connection between the two is very limited. And something where actually Farm Access with its mom care program has demonstrated that if you combine that, you increase health outcomes, but you also are much more efficient and effective with the amount of money available. And I think that is something that we all need to use this digitalization for. When it comes to this technology, another important point to reflect upon is that let's not finance it through donor funding. When USAID pulled out, we were all in trouble, especially I know some examples here in Kenya. So having sustainable financing, especially on the public infrastructure side, I think is extremely important, and it needs to be domestic financing. Otherwise, you are in trouble the moment these donor funding pull out. I think another point that I'd like to make, again about the universal healthcare coverage, is when we talk about data sharing, a lot of it is interoperability. This session is interoperability. But as I made my point earlier, it should also be about the legal requirements. But we're also assuming that the moment things are interoperable, happily data will exchange between healthcare providers and social health insurance and private health insurance and the government and all these different players. But there is a tension between this data flow. There might be information that is between you and your doctor, maybe about how your diabetes was treated and you shouldn't be having that second beer on a Saturday night, and yet you had that second beer. If that information is shared, and it should be shared between you and your doctor and your healthy behavior, suppose that is shared with your insurance company. And now they say you haven't been sticking to your healthy behavior. I'm going to increase your premium. This is unwanted behavior. If your data is out there, and there's now a huge debate also on international data sharing, fantastic for pandemic preparedness, but what happens if you're stopped at the border of a country because they see that you maybe had an abortion, or you are HIV positive, or you are TB positive? So we need to think about these negative side effects and make sure that we don't just regulate them as a default and say, oh, we need to protect, because there is a value of sharing data, especially when it comes to pandemic preparedness and other activities. And I think that's the last point that I wanted to make on this as a lesson learned. We are, in a way, a little bit trying to develop an Uber and asking the taxi company how to do it. So our thought leaderships is in healthcare facilities and insurance companies, but healthcare is a service. You are buying a service, you're not buying a hospital. So making sure that when we think about patient centricity in setting up digitalization systems, it's not just about knowing that Nicole went to this healthcare facility, it's being able to make patients an active participant in the healthcare system, knowing who they are, being able to predict if they stay on medication, if they are vulnerable to certain infections, and what that means in the response of the healthcare system, I think is going to create the trust also of patients being an active participant in the healthcare system to start using these digitalization methods. Because if they are just a data source, that is not enough. They need to be a participant in healthcare services. Thank you.
Thank you, Nicole. You've reminded me something that I often hear, that diseases don't read textbooks, and you said patients are not in to buy hospitals, they're purchasing good healthcare. And you further say that we should finance it domestically or using local resources. And of course, that means leveraging quite a bit on private sector. To Dr. Gakombe, we have many conversations, and one of them was a survey you had done at your facility. And your people said that the system you used to run the hospital is the biggest asset, and if that wasn't there, then it would be difficult for them to continue with work. That said, what do you think, what's your perspective, and most of the private sector's perspective when it comes to interoperability in care, and more so moving from ideas, piloting, and finally to scale? Karibu.
Thank you, Tim, and good morning. On top of the job I do at GDHF being chairman, I run a hospital that I started in 1994. And by the third year, I'd figured out that I was in charge but not in control. Because I depended on other people to tell me what was going on. And that's where our digitization journey started, because I wanted to know what's going on. About patients, about money, about our relationships with the insurers. And so we are still pursuing that journey today. The goals keep changing, because once we finish with one hill, we find another. But fundamentally, it's been driven by the need to be smart for patients, smart for staff and doctors, smart for the shareholders, and smart for government. That's our four-pronged approach, that whatever we do must make sense to each of those stakeholders. And among the first opportunities, not just for Metropolitan, but for the country, was and still remains a need to save money. We do not have a lot to spend on health per capita. So we have to be very smart in deploying the resources that we have. If a job can be done by a nurse instead of an obstetrician, if it can be done by a healthcare assistant instead of a nurse, if it can be done by a medical officer instead of a consultant, then we are getting more value for the money we are spending, and we are improving access, because many of the consultants we have, they can't go around one per county. If you look at all the nephrologists Kenya has, if you distribute them around the counties, 7 counties will be left without, or thereabouts. And the same applies to many other specialties. And that then means we have a great opportunity to take the knowledge from those who know in Kenya and across the world to enable lower level staff to deliver quality care, using co-pilots, AI tools, whatever you want to call it. But you make sure that that nurse is a nurse plus, because next to her, maybe invisible, but next to her is a co-pilot who is assisting him or her to ensure that they do not crash. So for me, one of our first opportunities is getting more value from our healthcare workers. The second one, if you read Kenyan statistics, and I don't quite agree with all of them, it is said that 40% of money is lost in the payer-provider link is lost to fraudsters, right? So we should all be focusing on making sure that these 40% actually benefits patients by providing interoperability and improved controls in that chain of data, from the individual who is getting insurance to the employer who is buying insurance to the insurance company, even if it's SHA or a private one, to a benefit administration desk in a hospital, and the claims that need to be sent back. And that's a route we took, because we needed to save money for the next investment. Because if IT resources are seen by finance merely as a cost, they'd rather buy an MRI or a CT or the next lab machine, because anytime they see the crew, they see choice, they see an expense, they do not see a benefit. So we need to move the investments in IT from merely a cost to real value. So the money we continue to invest today comes from savings. And to give you an example, and to go back to the point he made, we were able to move from a 70% recovery rate from insurance companies to 97% consistently. And for some of the people who pay us money, we've recovered 100% of our claims 5 years in a row. So if you are competing with us and you're at 80% and we're at 100, we have 20% more money to invest in AI tools, to invest in improving care for patients. And that, to me, is the first significant value proposition for interoperability. Today, and Joyce has alluded to it, governments the world over wait until you create things and they then come and regulate them. So it's no wonder that we got into this space in 1994 and DHA was born 1.5 years back. That's the natural set of things. No government begins to regulate driving until there are a number of cars on the road that are beginning to crash into each other. So you bring order by creating regulation, governance, rules, and enforcement mechanisms. And today we have a number of enablers. DHA is one of them, because historically, those who've invested, it's depended perhaps on a CEO or somebody or an owner who is interested or sees value in digitization. But now with DHA, no hospital has a choice.
Yep.
You cannot run manually anymore if you wish to submit any claim to SHA. It is simply impossible. So DHA and the Health Information Superhighway is now an enabler to all of us. COVID was another enabler, because insurance companies suddenly told us, please don't send manual claims. We've been trying for 15 years. Then they eliminated the forms in 6 weeks, courtesy of COVID, because they no longer wanted germs and viruses delivered to their premises. So we have to thank COVID, never mind all the devastation, for some of the digitization that has happened. And of course, there is mobile telephony, because we now have connectivity, or telephony, we now have connectivity across the country. And M-Pesa allowed Joyce and I and Dr. Theuri to do a teleconsult and be paid. Because one of the problems with telemedicine, we've always done telemedicine, making a call, doctor, I have this pain and so on and so forth. What should I do? So telemedicine is not new, it's as old as the telephone. The problem was, how do you get paid? The call is on a line, but the money is physical. So most of us did a lot of free telemedicine over the years. Now we can say, Tuma, send to this till number. You know, before the consultation. So the money can also flow digitally. Because before, information could flow, service could flow, but the money couldn't. Now the money too can flow. So there are enablers that we now have, not to mention open source tools for developing software, which is what we've used in our case, and open source tools for AI. So today, and that's one of Africa's greatest advantages in this space, is that there is a lot of stuff. People have been very generous in donating to the world, whatever their motivation, that we can use to create solutions to meet our needs. And our needs are greater than everyone's else, because we have very little of everything. And we have very large countries where you need to stay connected from patient to facility and back. And one of my challenges, and I'll leave it with you, is that we figured out that, patients are not a snapshot. They're a video. It's a whole story from birth to the grave. But oftentimes you have 15 minutes to listen to the patient's story and do everything and come up with a clinical impression, then start investigating, right? And my dream, my hope, my aspiration is that one day we will know our patients from cradle to the time we are doing the next consult, and that this data will have been sifted out, because you can't read it all in those 15 minutes, and we can therefore make much better decisions. As I close, Joyce needs to help us, and Wanye needs to help us, and I know they're trying to help us. You see, we are 45 ethnic groups in this country, each with a language. So we had to figure out that although English was colonial, it made sense for us to retain it as a way to stay connected, across all our communities. So at home you could speak mother tongue, as we call it, but when you hit the streets, Kenyan government was very clever to say English is our official language.
Yes.
And Kiswahili is our national language, because we wanted to feel independent. So we kept to one national, one official. So healthcare also needs official languages. What do we call lab tests? What do we call patients? What do we call everything? So that when Aga Khan gets my data, they can make sense of it, because we have a national language that we are using as common references for everything that we do. That's my challenge now, because I am at a position where I can share, but some things I'm sharing in Greek and various other languages that the next facility, the next doctor, the next nurse has no clue what it is that we are talking about, and therefore the data is useless to them. So I'm very supportive of Joyce. That's why I sat next to her.
Thank you.
We are busy integrating our systems, and you're looking forward to common references across the entire sector. Thanks, Tim.
Thank you, Chairman. Steve, I'd like to bring you now. You design systems. What are among the design choices that you've made in the course of your journey that have brought most impact? And I think together with that, technology fragmentation, I think is something that you wake up each day to try and solve. So please enlighten our audience on that in maybe 3 minutes. Yeah.
Thank you very much, Dr. Theory, and my apologies for running late. I think Dr. Akombe has made my work really easy.
Yeah.
I think he's laid out the importance considerations to enable me answer you really, really directly. And I think his last statement about healthcare needs a language is exactly the answer I have for you. I think the technical consideration, which is what Dr. Joyce is doing with the DHA and many others who are also in the audience, is exactly that, something that I think we all harp on about, standards. I think if we were to unpack what standards is, I really can't be prouder than what Dr. Akombe has said. I think standards comes down to the notion that we agree on how to do things. It's as simple as that. We sit together and we say that when I speak like I'm speaking, you're understanding what I'm saying. You can come here and speak in Kikuyu, only very few people will understand me. So I think the fact that we've gotten to a place where we say this is our official language, and we did that for a reason, because we need to communicate and understand each other. That's what standards are in digital health. And again, thankful to what the Digital Health Agency is doing. They've set up the technology service. Again, it's nothing complicated. I think, as been mentioned by Chairman, we've been doing this for a long time. I remember when I started working with Dr. Joyce many years ago at the HIV program in Kenya. One of the breakthroughs that at that time we thought was very innovative was coming up with a standard indicator manual, where we could say that gender in Kenya is male and female, period. Now, of course, there are many more genders. Yeah. We could define things and say that this is how we call things, as simple as that. Yep. And I think the surprising thing is that, for healthcare professionals, which all of you are here, that is never contentious. You've got clinical guidelines that specify exactly how things are done. So there is no ambiguity at all. And so we pick that from what has been defined by the healthcare profession, obviously that came out of clinical trials, and then you say this is how things are done, and then you translate that into computer understandable language. So the technology service that has been set up by the DHA is exactly that. Computers don't understand the complexity, the ambiguity of human language, so we have to break that down into codes. SNOMED is one of those codes. LOINC, so each one of them has that. And I think, as Dr. Akombe has said, the challenge has been the effort of translating those codes into information systems. Yep. There is a cost to it because people have been building systems and using them for a long time. There is capacity required. Not everybody can go into a system and build the codes in. And I think that's what we're grappling. But I think, as Dr. Akombe said, we need to step back and simplify the notion of standards. We can never move forward and we can never have coordinated care if we don't agree what we call things, what they mean, and what they don't mean. We cannot move forward if we also don't agree, things as simple as tariff. These are the services offered by SHA, these are how much they cost. Every system needs to understand that and bill correctly. So I think the simple answer to your question, Dr. Theory, is the technical approach you all need to embrace, and an answer to Dr. Akombe's challenge is you all need to embrace standards, and Kenya is way ahead. Thankfully to Dr. Joyce, we have technology. So if you're working in Kenya, please comply to standards that are already defined. Thank you.
Thank you. You said simplicity is sacred, and let's comply to standards. Fantastic. Joram, you head the primary healthcare division in Kisumu County. And I've always said it begins and ends at the community. Whereas it's beginning there, you're also part of the last mile of service delivery. And we don't tend to see a lot of digital technical solutions happening at that level. But Kisumu County has done quite some fantastic things on that front. My question to you is, in that journey of integrating a population that maybe has not been techno-savvy before, and trying to bring them to what Steve is talking about, what has been your experience with that in some 3 minutes?
Thank you, Dr. Theory. In Kisumu, we have major challenges that I would like to outline to us. Number one is high maternal and perinatal mortality. Our maternal and perinatal mortality ratio stands at 343 per 100,000 live births. That is maternal mortality ratio as at 2022. If we look at the facility maternal mortality ratio, it's lower than that, around 190. We also have a high perinatal mortality ratio. At the same time, we have high number of private facilities. 40% of our health facilities are private. And that is not directly controlled by the county government of Kisumu. They have their own management that controls how things are done. I would like to say that digitalization is not something new to Kisumu. It has been there, and it is widespread. The challenge is with fragmentation of data systems, and that leads to loss of follow-up of these patients. And at the end of the day, we have high maternal and perinatal mortalities. Kisumu, we decided to digitalize the workflows in the community health systems, because that is where health begins. And that was our first agenda, to digitalize the community health system through ICHIS. And this community health promoters were trained and adopted the systems. And at the community, we have the community health promoters doing health promotion and are able to identify high-risk pregnancies and refer them to the health facilities. So through that, we've been able to see these people reaching the hospital at the right time. And we believe that systems should be interoperable to make this process easier and faster. And we have an opportunity to interoperate and integrate these health systems being used at the community and facilities, so that we are able to track the patient journey right from the community into the facility. And our dream is having one patient file, and the patient is able to be tracked from the community to the facility, and we are able to track the patient whether they go to the private facility, or they go to the faith-based facility, or they go to the public facility. It's one patient with one record. And that is our aim, to reduce these poor outcomes. Thank you.
Thank you, Joram. I think I can't put it any better that the systems that we have, if they allow our patients to come into facilities on time, then some of those ratios and matrices you've mentioned begin to improve. As I come to a close of the session, I'll throw one question each to each of my panelists. And in 1 minute, Steve, I'll begin with you. If money is no item and the continent is in your hands, what is the one thing you would provide to each of these countries that would allow them to move from piloting to scale?
Standards.
Standard, yeah? Fantastic. Joyce, what regulatory gap would you want to propose for us to solve? And don't say standards.
I actually think we have enough regulations for now. I mean, legal framework. What we need to do is implement it, and implement it roho safi, wholeheartedly. And all stakeholders, just wanting to do what is in the regulations because they are well thought through and they actually provide, the pathway to delivering the vision that we have for digital health transformation. Yes.
Thank you. Dr. Kakombe, trust is a currency through which digital systems operate. Your dream is for a patient to have a record that you can look at and make a quick decision. What is the one enabler you would have in your thoughts that would bring that to life?
My dream is the one you've mentioned. My waking nightmare is cybersecurity.
Okay.
People to give their data to us. For us to give that data to DHA, there has to be absolute trust. Otherwise, patients will prefer to keep a book that they'll have to give you to open. And that means all these things we want to do will not be possible. So we must do everything we can, not just in cybersecurity, but everything we can to make people feel that they are safe. Whether it's government or private providers, everyone must constantly ask the question, does what I am doing increase or decrease public trust in connected systems? It should be the reference point, always. Thank you.
Thank you. Joram, I think you work in such a critical area or point of healthcare service delivery. For you, what is the one thing that has worked that you'd like to see happen at national level?
In Kisumu, we have implemented Safe Mama Tech project with the help of Farm Access. And Safe Mama Tech project aims to integrate solutions so that we have a mother, a woman who is followed up throughout the pregnancy journey, from the time they conceive to the time they deliver to the time they come for their postnatal checkups and the immunization of the child. So at Safe Mama Tech project has three major aims. One is to digitally integrate all systems. We leverage on digitalization to be able to follow up the mother longitudinally through the pregnancy journey. And it starts from the community, where the pregnant mother is mapped and referred to the health facility. How can this referral communication be made visible to the facility? And it is through interoperability. Two is at the facility, how can facilities be enabled to offer quality healthcare services? And we have institutionalized Safe Care app to be able to improve quality within our health facilities. And I would like to mention that Safe Mama Tech project is being piloted in one of the 35 wards within Kisumu called Kolua East Ward. And it started in October 2024. And we've been able to see remarkable improvement in quality of services at the at the primary healthcare facility level, level 2 and level 3 facilities. And we started at around 20%, and quality has improved to 50%. And through that improvement, we've seen service uptake at the level 2 and level 3. Mothers have now confidence to come to our facilities to seek care antenatally. They come to deliver in our facilities. And our antenatal coverage within Kolua East has improved by 30%. And deliveries improved by 25%. So that shows remarkable improvement. The third component of Safe Mama Tech is value-based incentivization. When a CHP refers the mother to the health facilities and they refer them early, we are able to incentivize them. And when facilities do self-care quality audit, quality assessment, and we identify the gaps through the assessment, there are action points that are given to the facilities to obtain. When the facilities obtain these action points, they are also incentivized, and that is value-based incentivization. Finally, we have Wanda electronic health records. It's electronic health records that is AI-based, that is able to risk stratify the pregnant women during pregnancy and categorize them based on their risk into red alerts, and be able to raise red alerts and yellow alerts. Red alerts are the high-risk pregnancies, and the yellow alerts are the intermediate-risk pregnancies. It does not stop at that. It goes further to tell the healthcare worker at the primary care level or at the hospital what to do next using AI. And Jacaranda prompts has been able to, also AI-enabled, has been able to send prompts to the mothers or pregnant women or postnatal women once enrolled into the platform. The mother is able to get information and be able to identify danger signs and get to the health facility. Thank you.
Thank you. Nicole, what do you think the future looks like for interoperability? And I will remove AI from among the answers that you will give us.
Thank you. I mean, first of all, I really have to compliment Kisumu County. We've been here now for a whole week, and people very often sort of say, oh, pilotitis, we need to move beyond pilotitis, which is true, but I think what is a very good and careful reflection of Kisumu County is that you're building the trust with the partnerships, and along every step of the way, demonstrating the value for the pregnant women, demonstrating the value for the healthcare facilities, demonstrating smarter payments and very strong evidence-based better health outcomes, which is such an important part, and then carefully scaling, building the business model. Because very often we throw digital systems at healthcare systems that are already fragmented, hoping they sort of stick together. And I think this is a great example with careful scaling that you can actually do that. So where do we move further? I think we're already seeing the building blocks of that in Kisumu. The power of digital technology is not just about knowing what is happening in the healthcare facility, is knowing what is happening to patients. And information that is relevant is not only information that is about your healthcare. The lines of what is healthcare information, health information, and social information are rapidly blurring, and they impact decision-making and risk stratification. So to just use an example, when COVID happened, we talked about it a little bit here in Kenya, the response, the COVID response in Kenya, and I was living there here at the moment, was a European response. We closed the whole country and we locked the elderly up. Why? Because in Europe we bring our elderly people together in a home. Terrible things happened. That was really where the infection surged. But the social determinants in Africa are very different. Most elderly people live very comfortably and very safe in the village. And very often they had been infected previously with diseases like Dr. next to me is saying, if you would have seen that healthcare journey, if we would have been able to see that, we would have been able to determine much earlier that the pandemic response was very different in African people compared to European people. Now, it was all hashtag my first pandemic for all of us, right? So this is not blaming anyone on decision-making with the information that we had at that time. But if we had known, we would have had a different response. And we probably wouldn't have closed the schools in Africa, especially in places where kids were not connected to schools. And in Uganda, 1 in 5 children has not gone back to school after the closing of schools. Those are, and these are the numbers that we know, so they might even be higher. So this means that the side effects of COVID are going to be there at least for 2 generations to come. Why? Because we had no idea what was happening in the community and who it was happening for. So the true power of AI technology moving forward is not just about ensuring the right protocols are followed, extremely important. It's not just about ensuring that the government has the rightful information to make decisions, but also regulate these tools. Extremely important. We need to make sure that these new tools, we understand what they do and we mitigate harm. But we also need to be prepared for a world where this personal information that can be so extremely useful and that we should be unlocking the power, at the same time also really needs to be protected. So thinking through what information has to be shared and what information is personal and should not be shared, I think is the big step ahead. Now, the last point I want to sort of part with is somebody's going to figure this out. And my concern, and my team told me I shouldn't be saying very offensive things, but now I'm just going to say a few things that are maybe a little bit on the edge. I'll try to behave. But we live in a world where there are 3 or 4 big tech companies in the United States waiting to invest in this. And the moment they come into our countries, and this is not an African problem, this is a global problem, we run at a risk of starting digital colonies. And we hand over our data, we hand over our information, we think we get a good deal, but it is like your boss telling you, hey, you work for me, you get a free lunch. That's not a good deal. I need to be paid. What is the value for information? And we don't know this. And we as a global community need to get our act together and invest in this, because we're sitting back and we're waiting for this to happen. And we talk in conferences like this and regulation and all these important stuff, but we need to bring in the action. Investment in a public infrastructure that promotes data solidarity, public ownership, data sovereignty and responsible AI, and not irresponsible AI in the back where you don't know what is happening in your data. Sustainable financing so that we are not dependent on the erratic financing behavior of international development partners, and making sure that that value creation that I very much see is then brought to the owners, the originators of the data, which is in this case Kenyan citizens, being in control and being active participants in which data they want to share and which data, with 45 different cultures in Kenya alone, is also protected and should be nobody's business. So we need to get to action and make sure that our healthcare data is a public good and not owned by 3 or 4 big tech companies. Thank you.
Thank you. I think you wrap it very well, where visibility should not be confused for transparency, and the systems that we do have should work for the people and not the technology companies that bring the systems to us. I have 2 minutes. I will take 1 question from the audience. The first hand that goes up, and I have a hand up there. Okay, we have a question online. We'll start with that, and then you can read that one for me. All right. So your clock is ticking. You have 30 seconds to ask your question.
Thank you so much. My name is Sarah Jarvine. I'm a journalist with DevEx. The U.S. State Department is moving around the continent, negotiating bilateral health deals with countries as part of the America First strategy. Kenya just signed a $1.6 billion deal. Kind of piggybacking off what you said, Nicole, what are some concerns around data sharing agreements in these negotiations, in these deals, and how should the continent work to protect data? And I addressed to Nicole, but if anyone else would like to talk about that as well, it would be appreciated. Thank you.
All right, Nicole, I'll ask you to take that and don't listen to your team. The depth of conversation is what moves the agenda. And also Joyce. So in 30 seconds, and then Joyce 30 seconds.
Yeah, I definitely want Joyce also to answer this question, but my 2 cents, this is what is happening, right? And they're closing the deals with all African countries. At the same point, we don't understand what the value of this data is, and we don't understand the implications of the reuse of data in, with all due respect, a country that is not very friendly to foreigners at the moment. And I think this is the reality what we're dealing with. So from my opinion, but as a global citizen, not as a Mzungu having opinion about what African people should be doing because before you know it, they're next in my country and saying they will deliver weapons to Ukraine in return for our data. I mean, there's all sorts of things possible. This is exactly the undesirable behavior that we should have a good answer to.
Thank you. Joyce?
Yeah. So, speaking as a person who was on the table when, defining what needs to come to Kenya and how the data sharing agreement needs to look like, for us, we are very clear. Our Kenyan health data is a national strategic asset, and we operate like that in everything that we're doing. Secondly, we have the relevant laws in place, our Data Protection Act, the Digital Health Act, that goes beyond the purview of personal PII level data. And that's exactly what we have put down in our agreements, that the Kenyan law supersedes any other law, and we are going to abide by what is provided in our laws. And the minister has actually put out, what is it called? An advisory on the same. I wouldn't call it an advisory, but a statement, a communique on the same. So I think the most important thing is for people to answer the question that we were asked. Just what is the value of your data? And how do you view it? And then what do you want to do about it? So at the end of the day, Kenya is a sovereign country. Kenyan data is a national strategic asset, and we have laws that we have to abide to. Thank you.
Thank you. Dr. Gakombe?
Thank you. Actually, that's the kind of point I was alluding to, that when something goes out saying Kenyan data will be shared with someone, and we are sitting with patients, and they are reading that, it makes all our work in the sector a lot more complicated. It complicates Joyce's job, it complicates mine, it complicates everyone's job. So it's a leadership that has to be extremely careful in what goes out there about what is happening to our data, because if the public does not have confidence, then they will not share it. And if they don't share it, then we cannot make the decisions that we'd like to make. If you may allow me 2 seconds. I assume many of the people here are in tech. I want to point out that we need to take full advantage of the county of devolution. Because unlike in the past where you had to go through MOH to get anything done, and it could take forever, now there are 47 incubators in the country, Kisumu being one of them. I represent Moranga because I'm the government's advisor on matters health. I know he was here earlier. Please take full advantage of counties as a place to do pilots, to showcase, and then it can be adopted nationally. It's one of the benefits that we can get from devolution. Thank you.
Amazing. It is now my privilege to wind this up, and I will ask that as my panelists can stand and we give them a clap. I think they have done a good job. They have done a good job. And my appeal to all of us as we go back to our homes, go back to our organizations, go back to our countries, these conversations must leave the room. They must leave the room, and we must ensure that they become action. Because a decision that we stay with on our desk is not a good decision. A decision must be made and be sent out to the people. Thank you so much from all of us, and do have yourselves a good rest of the day.
Thank you so much, Dr. Tim. You've even taken over my job of getting them to stand and round of applause from everyone, so I appreciate that. I'll tell you what is happening in the next session. You can take it over from there. Please join them for a photo, and as they're doing that, two things. I know there were many comments online, and one or two questions that I think were answered as the panel went on. I can see Festus, Ogada, David Wairum were both very inspired by what Kisumu County is doing. Nena gives a +1 on digital colonization and how it is a very real thing. Vincent actually wants to buy you a beer, Nicole, for that comment as well. And I think there's definitely been a lot of interaction. Nena, Festus, Vincent, Winfred, thank you so much for that online engagement. We really appreciate it. Ladies and gentlemen who are here with us, I'm trying to see if I can walk slowly and the camera will pan with me so that I do not lose you. We are going to go into a tea break, and we shall reconvene in our respective rooms at 11:15 sharp. So thank you so much for your time, and we'll see you all in a short moment. Same for you online. Thank you very much.